So I've been asked several times now to provide education with regards to this code sheet, quote unquote, also known as your cardiopulmonary resuscitation record. Um, this is a bit of an intimidating task for people who are not familiar with ACLS algorithms and who are not trained in resuscitation skills and knowledge. So this is mostly addressed to you, but this can also apply to anybody else who has a role to play in the resuscitation situation. So the first thing that I want to address is the word resuscitation. When we refer to a resuscitation, it doesn't necessarily mean that the patient has had a cardiac arrest or a respiratory arrest and they're pulseless. A patient who arrives with vital signs still present but is an imminent threat of having an arrest falls under resuscitation. So this record can be used for patients who are not yet crashed but are on their way. That is an appropriate time to pull this record out and document what's happening in the room. So that's the first piece. And for nurses, you can call a code blue before a patient arrests. If you've got a patient who is imminently going to crash, calling code blue is the best thing you can do for that patient and the team to get the resources in the room as quickly as possible. So I wanted to make sure that I address that word because sometimes we focus on only patients who have had an arrest and we are doing a resuscitation there. Resuscitation can mean a lot of things in the emergency world. The next piece of information that I wanted to make sure that I point out to you. So the accountability and responsibility of the person writing this document. So I feel like there's a fear at times that people feel if they put their name on this document that if something didn't happen during that resuscitation that they will be held directly responsible and accountable to that. And that is not accurate. So a resuscitation is done as a team effort. And in that team, there are two individuals who are held to the highest level of accountability in terms of making sure that the things that should have happened and in the right time frames. That person is the physician and your code team lead. That might be the same person in some situations. In other situations, your physician may direct part of the care and you may have a nurse code team leader who is sort of directing the resuscitation itself in the room. So those two people are the two people who have the most accountability. So do not feel that when you're writing on this document that you're putting yourself under the gun. It is a team collaboration, and those two individuals are actually the people who are more at risk when things don't happen the way that they should happen. So I wanted to alleviate that stress for people because I think it is a thing and it's a real thing. The next piece that I wanted to talk about is priorities during a cardiac resuscitation. So when we arrive in a room and there's a resuscitation happen, the number one priority is the middle piece of this document. This section with the grid that I'm highlighting right now, that is the number one priority when you grab this paper. If they're in the middle of something, this is the information that needs to happen in real time. So time frames are extremely important during a resuscitation because we have certain standards that we must follow when we resuscitate a patient. And those standards are dictated by our ACLS algorithms. And when times are indicated on this form, it helps to paint the picture on a chronological basis, what happened during what time frame for the patient. So you want to make sure that you accurately record times. In saying that, you want to make sure that you utilize the same clock, regardless of where you are. If you're using your clock on your phone or your watch, in the resuscitation room, I always recommend using the digital clock on the wall because that's the one that is intended to be the most accurate in the room. Everybody in the room needs to be following that same clock. So make sure as the recorder, if somebody's giving you a time, to clarify, did you get that from the digital clock on the wall? Or check your own times on your phone and make sure that the time that you've got is the time that's indicated by the person doing the task. Sometimes there'll be a discrepancy of a couple of minutes, but a discrepancy of a couple of minutes is where we can potentially create some litigation issues for ourselves. So we want to have accurate times. And I'm going to talk about time frames a little bit more in detail. So that's one of the first priorities, is making sure you have the times. When we do BLS, when we take resuscitation related courses, every nurse in the building has at minimum BLS. And in BLS, we learn that high quality CPR is the number one most important intervention that needs to be done during a cardiac arrest. So by that token, it is critically important that when we document information in any one of these lines, if there is CPR happening during that time frame, you want to make sure that you put a check mark in the box that CPR is ongoing. So if you're documenting a drug being given, or you're documenting any procedure that's happening, make sure that you also document here a time and high quality CPR. The more often you do that during a code, the better. And if there's nothing to write down and there's nothing going on and you're not sure what you should be writing down, that is the number one thing that you need to make sure that you're accounting for on your record, is that high quality CPR is happening. We want to minimize pauses during compressions as to the least amount of time possible. 10 seconds is the limit that we recommend. So if, as the recorder, if you're noticing that, a procedure is requiring the stopping of compressions and is taking longer than 10 seconds, it should be part of your responsibility to point out, hey, it's been 20 seconds since we stopped CPR. And that should, indicate to your team that they need to resume CPR and potentially revisit the procedure that they're doing. So that's probably one of the number one priorities that you can have during a resuscitation. If nothing else, we need to be able to document that we're doing high quality CPR. The next thing that we learn in BLS that is a important and priority task is defibrillation of rhythms that are shockable. So early on in a code, we're going to put our monitors on patients, and we're going to assess whether or not we have electrical cardiac activity to work with. And oftentimes that cardiac activity will be something that requires defibrillation. When you're documenting in this box, number one, the time is valuable. You want to make sure the time at which you perform this procedure in reference to the rest of the things that are happening. And you also want to indicate the joules, the amount of energy that the patient was shocked at. So typically this is going to be a 200. However, it can be between 120 and 200, depending on the size of the patient and the circumstances. Typically, you'll see 200 most often, but it's important as the recorder that you clarify. If somebody says defibrillating, typically your nurses will know to tell you that defibrillating at 150 joules or at 200 joules. Make sure that you document that value, and if no one has stated the value, ask, what did we defibrillate at? And document that value. So the third priority during a resuscitation is the administration of life-saving drugs. So there's a number of drugs here on this chart in this section here that may or may not be given during a code. However, it is the number one thing that you want to make sure that you have documented here. You want to make sure that when you're documenting the administration of a drug, for example, epinephrine, you're going to want to put the amount given, whether it was 1 milligram or another value. So epinephrine, just for the record, is typically a 1 milligram dose for all adults. So anytime epinephrine is administered, it will typically be a 1 milligram dose. However, it's important that everyone communicates clearly in the room 1 milligram of epinephrine administered at, and then the time frame of which that is given is also a very important part of this documentation. So make sure that you accurately capture both the dose and the time. Same thing for atropine. Atropine is a 1 milligram dose as well for most situations. So you want to make sure that you document it, because there are situations where it may be 0.5. So make sure that you accurately capture those. And again, the other drugs, same thing. You want to make sure that you have the dose and the time at which they're given. So back to epinephrine. So epinephrine is a pretty standard part of a resuscitation routine. And the time frames for epinephrine are typically 3 to 5 minutes. So your role as the recorder is to keep a separate time. Sometimes you'll want to use your smartphone and set its timer specifically for epinephrine. Or if you're good at managing the time frames just from the clock on the wall, that's fine as well. I recommend using a timer for epi. And then set your timer, and then every time it gets administered, you're going to reset that timer. And at the point of 3 minutes, your job will be to indicate to everybody in the room that 3 minutes has elapsed since the last epinephrine. And then that should cue your code team leaders or your physicians to administer a subsequent dose if it's appropriate at the time, or to reassess the status of the patient, and then administer the epinephrine. So one of the jobs that you have as a recorder is making sure that people know the time frames of that specific task, as well as, so typically CPR is provided for 2 minutes at a time and then reassessed during a cardiopulmonary resuscitation, or basic BLS. However, because we give epinephrine at 3-minute intervals, it is not unusual for the team to stop the resuscitation, or to stop compressions and assess the patient at the time frames at which the epinephrine is due. So that's not unusual, and it's acceptable. You should indicate if you're beyond that time frame for reassessment. Then you want to indicate to staff that, okay, it's been 2 minutes since we did the last compression assessment, and then somebody may say, okay, well, we'll wait till the epinephrine and we'll assess it at that point. And again, that is totally appropriate for the physician or the code team leader to make that decision at that point. You do want to make sure that when you're communicating or documenting to the team, that you've covered that high quality CPR is happening, as well as you want the BAG-VAG mouse, BVM BAG-VAG BAB-BAG valve mask resuscitation as well in that component, and you're just gonna need a checkbox for those two pieces and a time. And again, I can't emphasize, if there's nothing else going on and you're thinking you need to write something down, go ahead and write those down. Those are the most important pieces of any resuscitation. Make sure you're recording those values regularly. And if there is a situation where during the reassessment that the patient does have vital signs, we've achieved ROSC, or we've effectively resuscitated the patient, then you're going to want to make sure that the time of that is indicated, and that you've indicated as many of the vital signs values as are possible to you. You may not have a blood pressure yet, or you may not have an accurate SpO2, but you do want to make sure you record whatever values of that assessment are. And at some point or another, you'll also want to put here resuscitation successful, and then you can indicate whether it was a yes or a no. I would not do this immediately when you have one moment of ROSC, because it may only be temporary and the patient may recrash. So usually I want to make sure that once we're in the process now of keeping the patient alive, you do want to make sure that you check off this box that resuscitation was successful, and then ongoing documentation of vital signs during the time frames at which anything is happening, and whatever drugs and doses are being given to the patient. So that is the meat and potatoes and the most important part of the documentation. There's a lot of more information on this record that I'm going to go into very shortly. So the last thing that I wanted to talk about is this section right here. So the past medical history and medications. If you know anything about the patient during the resuscitation. You get information from a family member, or the paramedics give us additional information than what they gave during the time that they transferred the patient over, or you are present during the time of handoff and you have the opportunity to capture that information. Write down as much of the information history-wise as you can in this box here, because it can be very helpful to provide context to what approaches were taken for the patient. So do write in this box information about the patient, whether they were diabetic, whether they're a drug user, whether they were witnessed to collapse, whether they were not witnessed to collapse, all those things, whether they were VSA unseen, all those things can be added here in this box. Although they're covered over here as well in the document, but as much information as you know about the history, please do indicate it here. So for these comment boxes, so the comment boxes, if you feel like a checkbox doesn't accurately describe what you need to cover, or you're just not sure where to document something at the time of whatever is happening, if you write a time and then you go over here into this notes box, you can write whatever it is, ET tube inserted, whatever it might be. Those things typically will get captured in this box up here. So the airway securement and the advanced airway being inserted by the physician. You want to make sure who put in the airway as well. But all that information is usually captured up here in the box. But you know what? If you capture it here in the notes, it's not going to be a detrimental piece of the documentation. You can then, once you have an opportunity, fill out the rest of this information more accurately if you can. But putting the information in a note is not going to harm the documentation. The other thing here, so you'll notice that this is a new piece of our resuscitation records. So because we now have medical directives under the expense program, if something is administered to the patient and the physician is not in the room and it is a nursing decision that was made, it is important as the recorder that you indicate that that was a medical directive and not something that was driven by the physician. So such things as defibrillation and the administration of drugs, specifically these three drugs, epinephrine, atropine, and amiodarone, are part of a directive. The other thing is transcutaneous pacing is also part of that directive. So if we do any of those procedures, we want to indicate in this in this comment box that it was triggered by a medical directive and who the nurse was. It'll be your code team leader, but I would just indicate who the nurse is if you can. And that will cover that piece of the information. But again, anything you're not sure about, you may want to comment on the GCS of the patient. You may want to comment on, difficult IV starts, or why there might have been a delay in compressions, or why there might have been a delay in epinephrine and being administered. If there's any of those details happening in the room, the more information you provide here, the better it is for if there's any further investigation later down the line. The information is available on the sheet. So now I'm going to talk about the rest of the details on the page. So you should treat this record as you want to fill in as much of it as you possibly can as the recorder. So once the code is completed, you want to make sure that you go over the sheet and you fill out as much of the information as you can based on what you know. So we're going to have the date and time of the event. Those are things that you're going to want to try to capture early on. Obviously, the time at which you started your resuscitation will be a pretty good indication as to when you started your resuscitation. And then whether the patient was witnessed or not witnessed is an important detail because it determines how much time we will give to the resuscitation itself. And then the last scene well time is also part of that. Who discovered them? So were they discovered by EMS? Were they discovered by a family member? Was it by a nurse here in the unit? Did it happen in the resuscitation room? All that information is important to have because it basically reflects in which time frames things have happened if it was appropriate. And then the type of arrest. So if it's a cardiac arrest or respiratory arrest or unknown, you can select that if you can. If you had a set of initial vital signs, that is a valuable piece. So if the EMS gave you a set of vitals before they brought the patient in, or vitals that they had, please do write those in. And if you don't have those vital signs, then that is not a problem, because if a patient has had an arrest prior to arrival, you will not have vital signs, and vital signs are not the priority. High quality compressions is the priority. So hooking up a monitor is something we want to do at some point, but the first thing that we want to do is high quality CPR, no matter what. Whether the patient was breathing apneic or agonal. Agonal refers to what, colloquially we can call it guppy breathing, where somebody's like a fish out of water and just gasping but not really moving any air. That is a clear clinical sign that the patient is not effectively breathing and probably has arrested. So when you see agonal breaths, it's an important thing to document and to recognize as the nurse in the room that that patient probably needs CPR. Even though they're looking like they're making an effort to breathe, they will need some sort of intervention. And then so CPR initiate at staff. So again, we've covered that sort of down here, but it's nice to cover it up here. Fill in as much information as you can, whether it was a hospital code blue, which clock you used. So I referred to making sure that you've got a primary clock identified. So whatever clock in the room you're using, make sure everybody knows that's the clock we're using. And then so the time that the physician arrived, if the physician's not already in the room, and then the MRP. So during a code blue, we do usually call for the MRP if it's an inpatient. So what time the MRP arrived is also a piece of the information there. I would also, if I was on med-surg, I would also indicate in my notes here what time your ACLS trained emerg nurse or ICU nurse arrived to take lead on the code. That would be an important piece to put in that note box as far as I'm concerned. And then anesthesiology, those sort of things. So this is all pretty straightforward stuff. So an estimated weight is a valuable thing. If we can get that early on in the code and we have, a good indication of what the patient's weight is, I would get that value if you can. This is valuable more early in the code as opposed to after the fact, including like anything, the allergies or whatever that the patient may have had. You do want to make sure if this paper is all filled out really, really well, and there's no label to indicate who was the patient, it is not a very valuable piece of paper. So you do need to make sure that you've got a patient label on this. If a patient label is not available, it is perfectly acceptable to put the patient's identifiers. So just like anything else in healthcare, we need a name and a date of birth at minimum to identify the patient. If you have their QA number or any of those other medical record numbers, then do put it in here. But you want to have at minimum their name and date of birth handwritten in here if you can. Try to be as accurate as possible with your spelling and names. And if it's a John Doe situation, indicate the John Doe situation and make sure that you have clear dates. And if you have a suspected name, suspected Jim or whatever, write in as much information here as possible so that we can accurately identify the patient that required resuscitation. I already talked about the airway piece, so this is any airway management adjuncts that happen during the code. You can document them here, but you can also document them in your notes here if you're not sure where they fit in the sequence of things. And these are typically, if these things were done early on, you'll write them down immediately. However, these are more after the fact details probably that you're going to be filling out, and that's okay. Same thing with IVs. So if you can capture when IVs or IOs were started, or central lines or catheters or NG tubes were inserted, you can capture them here. But again, if you've captured them in your notes here during the resuscitation, it's not inappropriate to do that. And then to backtrack later once the code is completed and fill out these fields to make sure that the information is translated properly onto the record. So those are the main boxes up there. Down here, you'll notice that there's a couple pieces that I want to make sure. So the coroner being notified, if this is a coroner's case, you do want to make sure that you indicate that information. The time of death is a very important number from a legal documentation. So you do want to make sure that who pronounced the patient and the time of death, you're going to have that information. When they were transferred to the morgue, again, it's useful to have, but it's not necessarily going to be the deal breaker. But do try to capture this information when you move the patient, which may be several hours later. And then the MRP being notified and by the nurse. So if this is an emergency situation and the patient died and emerge, you do want to notify the MRP that their patient died. So that's where you would capture that information, or any family members that were notified as well. You're going to document that as well. Rhythm strips. So in current world, we do have rhythm strips that we need to print off from our monitors, and later in the Expanse modules, we will have the ability to capture that electronically. So make sure that whether you've captured electronically or on paper, that you've addressed this piece, because that information is valuable in terms of context of what things happen during the code. And then a post-code debrief. So more often than not, we are in a tremendous hurry to get back to the tasks that we've left behind during a code. Please, and this is more for your team leaders, but do take the time as a team to ask for these things. Let's, even if it's only a 2-minute debrief, close the curtain, the code is done, and just have a quick discussion as a team. How did it go? What did we get right? What did we get wrong? How does everybody feel? Does anybody need support? We do have services for counseling and that sort of stuff available to us. Different people cope with codes different ways. Please understand that some people who have been in the emergency department for 30 years, may not even flinch at a code, and then others may be completely puddles of tears and not able to cope or manage at all. And I've experienced varying levels of this myself, depending on the code and the situation. So do be mindful that people may need different levels of support, and please address this in the room. And if you feel that one of your colleagues is obviously not doing well, then please do address that. And suggest that they seek out some help, and ask your team leader maybe to follow up with them and do a code debrief, because it's a valuable piece of the learning experience, the reflective practice, as well as sometimes people need to walk through and talk through things to be able to cope with them internally as well. So please don't forget that part. And then this last box, from a legal standpoint, is one of the more important boxes. So you want to make sure that you've captured who is in the room, especially the people who were in charge, because they're, again, as I said early on in this, they are the most accountable bodies in the room. Those are the guys that are going to take the heat if things did not happen the way that they were supposed to. And as a recorder, you want to make sure that you've captured all of the people involved in the code. Even if it was a med student or even a high school student that did CPR, anybody in the room should be captured as best possible. Lastly, so you're probably not going to see this on your current records. You may or may not, depending on how quickly I can get this approved, but you will have this section here. This is just a reminder to do the reporting to the Trillium Gift of Life program, and capturing the number here. If you've captured the number here, great. It's typically done electronically. This is more a reminder that it has to be done. So if you can capture that information on here, then it would be greatly appreciated, because it does make tracking much easier. And that should be done within 1 hour of the death of the patient. So as the recorder, please, because you're the only one looking at this record sometimes, make sure that you've informed your team leads that you do need, especially if you're somebody from another unit and you're going back to your unit, do make sure that you communicate to the team that this piece needs to happen at some point or another, as a prompt. And I think that pretty much covers way more than I intended to talk about this subject, but I feel like there was a lot of confusion, a lot of anxiety around it. So I think I've covered everything that you need to know. We're going to be doing mock codes and practicing these things in real time, probably more frequently now. But I do hope that this has provided you the information that you were looking for. If not, feel free to reach out to me directly. Come find me on the unit, call me on my cell phone, or email me, and we'll set up a time and we can go through this resuscitation process a little bit more in more detail if you want to know more. I do recommend, if you have an opportunity to take ACLS or any additional training, that you do so as well. The more knowledge and training that you have during these cardiac arrest situations, the more comfortable you will be. And we're strongly encouraging all of our staff to seek out that opportunity, and oftentimes we're also compensating you for your time and paying for it. So you will need to clarify that with your managers at the time. However, that is there. So make sure that you're, taking the opportunity to gain all that knowledge and all that experience and training so that you can feel more comfortable when you're doing these resuscitations. Unfortunately, we're a small hospital, and we sometimes get thrown into the fire, and that can be quite intimidating. So I hope that I've made people a little bit more comfortable about this piece of that puzzle.